Anti-VEGFs, and this session is rightly named as Evolving Anti-VEGF Paradigms. Not only India, worldwide, because anti-VEGFs have taken the world by storm, and in fact today all the anti-VEGF users today have guts to challenge cataract surgery that हम भी कुछ करते हैं, but generally this has been dominated always by ophthalmology in India, where cataract surgeons and all the rates, CGHS, CCHS, सब cataract surgery वाले करते हैं. So today we will be discussing something about anti-VEGFs. You see, have been traditionally divided into first generation, second generation. First generation typified, started way back in 90s when Bacugen came, and after that there has been flood of anti-VEGFs in the market. Biosimilars have added more value to the treatment armamentarium also. And then came ranibizumab, then aflibercept, and then biosimilars were added. Then recently, for last couple of years, we have had brolucimab, then faricimab, then 8 milligram aflibercept also. So our aim is to discuss a threadbare, very frankly, with the users of these anti-VEGFs, how should we be treating our patients in this present era? Because not only patients, doctors are also confused, किस दवाई से शुरू करें और how to have a regimen. Because basic thing is that we have to act in the best interest of patient. Because if patient gains, not only he spreads your name, but becomes lifelong your follow-up also. So with this remarks, we will begin with Dr. Gagan Bhatia. He will tell us about the gold standard anti-VEGF, that is the original ranibizumab. And I have with me Dr. Tinku Bali, a prolific, VR consultant at Gangaram Hospital, and all of us will try to discuss and narrow it down so that what best can be done. Yes, Dr. Gagan.
Good morning, everybody. Thank you, Dr. Lalit, Dr. Tinku, and Novartis for this opportunity. So, as we're talking about evolving anti-VEGF, I think, can I have my slides, please? Yeah. So, as we talk about evolving anti-VEGFs, I think it is important that we go back to where we started, and it is always going back to the roots. So, a few of the slides have been provided to me by Novartis, so that is a disclaimer, and this is a disclaimer by Novartis as well. So coming to, taking you back to time when 2006, probably I was still in my, I'd finished my post-graduation. So, and I think many over here were probably not there as well. So in 2006, all I remember was there was the era where there was laser photocoagulation, which was even being used for DME as well as for AMD. And I remember the time when, the only thing that we knew about AMD was that if you find a hot spot, you laser it. And visual acuity gain was not something that was talked about during those times, and it was only when the first molecule came in, which was ranibizumab in 2006, which with their Marina and Anchor trial, and the difference in visual acuity gain that it made basically changed the paradigm of the way that we were seeing these diseases, where treating the disease is one thing, but getting visual gain out of it and talking about alphabet gain and line letter gain was something that came into purview. Since then, obviously, anti-VEGFs have changed the way that we look at diseases now. It's really reduced, the role of reduction in the preventable blindness all over the globe. So, but where does ranibizumab stay, or where does it stand today? So this was the first innovator molecule. It was the first molecule. I think we proudly, all of us have used this molecule and grown with it. But then there are a few points which we could discuss today, and which also brings us. The music is not from my side. So this was the first molecule, and then when we talk about the evidence and efficacy, we talk about the innovator edge and the pharmacoeconomics, and these 3 points are something that kind of needs to be discussed when we talk about an innovator molecule and we go through the journey of anti-VEGFs in the world. So coming to the
AV people, can you please help? ये तो आवाज़ बहुत आ रही है.
So first we come to.
Speaking. तो की आवाज आ रही है.
So when we talk about the original molecule, I think this is the only molecule which has the maximum number of indications, and it has the maximum number of, probably the maximum number of trials that are there, and the biggest thing is the maximum number of real world evidence. And what it basically supports is also, you know, the trials and the usage and the evidence that we have for over 730,000 patients all over the world. So coming to, you know, there were some landmark trials which were done with ranibizumab, the original molecule, where, you know, it kind of obviously was better than bevacizumab in studies, whereas it was also comparable to the newer anti-VEGF, which was aflibercept. The rival study also told us the safety profile of the molecule, along with, you know, aflibercept, and also about the similar number of injections. So if you talk about pharmacoeconomics, then obviously with similar number of injections with a costlier molecule and this molecule in today's world would probably make a difference. The similar kind of evidence was also seen in the treatment of DME, where you know, anti-VEGFs along with prompt laser or deferred laser, whereas anti-VEGFs played a very major role. And you know, I remember during those olden days where central involving and non-central involving DME was the talk. And we used to always talk about, okay, whether you give the laser burn here or you don't give the laser burn here, or you see a scotoma, you don't see a scotoma. Whereas with the advent of anti-VEGFs, we kind of started talking about letter gains and how many line gains are we going to get. So similar was the story with RVO, and ranibizumab has had its bold print as far as treating RVO is concerned. So now we come to the Luminous trial, which was basically real-world evidence. So we've all used Eccentrix or Lucentis over the years, and this was the biggest trial, which basically was over 42 countries with 30,000 patients involved in 488 sites. And it was amazing to see that the injection was working and worked very well across all diseases that we know of, where we would use an anti-VEGF molecule. And this was not only the early gains, whereas you know, the long-term arms of these studies of the study also showed that this was persistent gain that was seen over the long term. Now coming to the innovator edge, this was we call this innovator not just because it was the first molecule, but there is a difference. So now that we have biosimilars, and this is something that is very important for us clinicians as well to know, that when we talk about an innovator molecule, the difference is basically that the molecule has to undergo you know, clearances for each and every step of clearing a molecule. Whereas when we talk about a biosimilar, it is a single process of clearing where all these properties, you know, the clinical studies, pharmacological, non-clinical studies, and the analytical data is characterized into a single club, and then the molecule is kind of, is approved for use. So it is basically a totality of evidence, and not the single step process of clearing. So if an innovator molecule fails even one single step, that molecule is not taken into consideration. Whereas in a biosimilar, that is not the true case. So when I say that, and the other problem is that biosimilar, the approval process is not fixed globally. If you see, there are different biosimilars all over the world, and they all have different ways of clearing in their respective countries. And why this information is important is because we are going to be faced for further molecules which are biosimilars. So ultimately, having that innovator edge does help. Now, the second question is that whether these biosimilars are also interchangeable. When I talk about interchangeability, is that these molecules can be substituted without a separate prescription, or it can be substituted for a particular condition without any difference in any of the quality characters. So there is only one insulin drug in the world which is actually interchangeable. Other than that, none of these molecules are frankly interchangeable. So this is one important point, and especially this point is important with newer biosimilars which are coming in the world now. So coming to pharmacoeconomics, this was an optimized calculator by Novartis, which again compared, basically if you compared a ranibizumab biosimilar to the original molecule, I think the costing is pretty much almost the same over the years. So coming to a few examples, this was a patient with a 618 N18 vision with this kind of a CNVM and fluid and cystic spaces. And in 3 loading doses, the patient recovered very well with Eccentrix. We went ahead to do a multimodal imaging at that time and just acquired the OCTA, and you see this network over there. The patient continued with treat and extend treatment, and this is now a follow-up almost 7 or 8 years, and the patient is doing well only on Eccentrix. This was a second case, a 74-year-old male, again with a hotspot on the ICG and a very nice network on the Octa. And this case, I probably would not have used eccentrics, but the patient chose eccentric at that time because of financial restraints and also clearances that they have. And the patient is 6'6" today with that kind of an OCT. I don't know how, but. And this is a case of chronic DME. I think in these kind of cases, I think Ozurdex would probably be one, or if this patient was not responding, I would have probably given a Pagenex for that matter, or even an Eylea. But for whatever constraints, again, the patient was given eccentrics because he chose to take eccentrics because he was shifted through many molecules at other places. But he said that no, there was a time when Lucentis I used to get and I used to get better. So Lucentis was given and then we got a Vio effect, even in this day and age of very good molecules in the country. This was again a lasered RVO. This patient was again under some scheme, and then this again is kind of a chronic DME. The probably RVO where you probably would not use an innovator molecule or Lucentis or eccentrics with newer this thing, but then finally with this patient also chose eccentrics and kind of improved immediately with 1 or 2 injections. So I would probably just say that, yes, we have gone through the line, but then the innovator molecule still holds their chance. It still holds their value today in the market. There are a numerous number of examples which can be taken out, and we all have a lot of robust data to kind of support this, that the risk benefit ratio of a molecule, innovator molecule, still holds true with the backing of the studies that they have. We know of all the complications. We know we ourselves have a lot of real world evidence with us. And so probably over the last 18 years with long-term data, I think it is still a robust molecule and could be used in our armamentarium. I think interchangeability is one aspect that kind of has been brought out, especially when I read through this presentation as well, and which kind of makes me think with newer biosimilars coming into the market, where we stand with innovator molecules. And also the biosimilar changeability. When we talk about international data and we talk about biosimilars international data, I think the process of approval is very different from what every country is following. So I don't know whether it is right to just take that data and kind of put it across the board with thinking about whether we're going to get the similar results. And I think it's important that as kind of Novartis has put their data across through over us, I think we also have the responsibility of standardizing data assessment and acquisition for our real world evidence through these molecules over the years. Thank you.
Thank you, Gagan. Let's have some discussion on this topic itself. So for you, you still don't believe in silver or platinum. Old is gold for you?
No, old is gold because old is gold.
Old is gold?
Because old is gold, but...
no, let's be very honest. Do you think that biosimilars don't work? Or?
No, I believe, sir, I believe that all molecules work. It's not that all molecules don't work. This topic was basically intended, or this talk is basically intended to the way that that there is innovator edge that is there. I think
Do you use biosimilars in your practice?
A lot.
A lot.
A lot.
So what is the edge which original molecule has?
Sir, original molecule I believe I don't believe that there is a very huge difference between actually the real world evidence or data that I have between biosimilars and the original molecule. But if you talk about trust and when you discuss with the patient.
The whole world is moving towards biosimilars.
Yes.
Why are you wanting to retrace it back?
It is retrace it back to a certain select
The reason
cases.
I'm asking is because even US, Western countries, they have approved so many biosimilars. India was the first biosimilar country in the world. So old is gold. I agree. कहावत के लिए तो अच्छा है. Old is gold, but it has to have an edge. You see, apart from raising doubts about those studies which you have shown reverse pyramid and Sida pyramid, but that is what DCGI wants. Actually, that's not that the biosimilar industry is not working in that direction. That's what they want.
No, biosimilar industry is working very, very well. I don't believe that biosimilar industry is not working, but what I basically intend to say is that I'm not at all against biosimilars, and rather I think a large part of my practice is on biosimilars and not on eccentrics or Lucentis anymore. But I think the idea of this session was to take you through the history of Lucentis. And today also, I think probably during a discussion with the patient, probably the trust issue with the innovator molecule does come in at times.
That is the single most important
Yeah.
fact that you said that, lot of trials, lot of studies, lot of real world data,
Yeah.
maximum number of patients, what you said, 73 lakhs or whatever
Yeah.
patients have been testimony to the fact of its working. In case you want, I don't know whether once you are wanting your eye, you would maybe prefer a innovator molecule. Is
So
that so?
My eye, I would definitely prefer the newer molecule.
Yeah, yeah. Yes,
so I think
Tinko?
it's not the biosimilars, it's the influx of a plethora of biosimilars that are coming in. And most of them, I mean, some of them over the years have had a number of studies, but the newer molecules, the newer biosimilars that are coming have very short-term studies, they don't have enough patients, or they don't have enough data or enough, long-term results. So that is where we have to hold our hands. With the newer biomoleculars, till we have very robust data, I think I would hold my hand in using every new biosimilar that comes into the market, and there's a glut of them now coming in.
I agree with this point because you see, all of us practice, real world data or evidence-based medicine. The more the longevity of that drug, the more the people have practiced and the more publications are there on that. So you tend to have more faith or belief in that. But this may be the safest. I agree with you. A lot of my patients still tell me,
Yeah.
Dr. Sahab, वो Lucentis आप लगा दो. तो
Agreed.
मैंने
And
Lucentis तो नहीं है.
I also come across, a very practical thing, but a lot of government schemes are going in with biosimilars, and I don't find anything wrong in that. I have wonderful results with a lot of biosimilars.
How do you tackle this situation? Maybe Vikram, everybody
Also,
can
once
answer.
I wanted to
Yeah.
make one point regarding your question, that you said what is the edge. So only edge that we also find now, that so we have had one patient who had Avastin, many Avastins before. She got one eye injected with Avastin. She got some complications with Avastin. So that was in 2016-17. So then other eye also she has. Then she was getting Eylea, and then in between she got inflammation with Eylea, and now her disease was again active, and this was the only seeing eye. And we trusted on eccentrics, so discussed with patient, and I think that is the best edge, that it is still the safest. So we've not had, and now we have shifted her to eccentrics.
No, what I was wanting to know from Vikram and Ramesh and other people is, you see, I have had not one but multiple times this issue because we started Lucentis in this country long time back. Patient comes to you, Dr. Sahab, मुझे Lucentis लगा दें, तो वो लगा दें, not this, and he gets approval for say any biosimilar. How do you tackle this situation? They will ask you pointedly, sir, Dr. Sahab, same ही molecule है या different है? So I am facing challenges. That because he actually brought from his dispensary.
So I get your point, sir, that it is sometimes difficult to convince the patient, but I think that is where we do say that now it's, of course, it's an Indian drug. Whatever biosimilars that we have right now, most of them are Indians. So we do say that, and now it has been almost 7-8 years, more than that almost, and it also has a good track record. So I think that is the only answer
Ramesh,
for that.
you have had any patient where there is a patient of RV or any disease, he is not responding to biosimilar but has responded to innovator. Same molecule, ranibizumab, biosimilar ranibizumab. Mike, can you put on the mic? AV.
Efficacy-wise, it doesn't change too much, to be very frank. What doesn't work?
Safety. It's the
Safety is
issue.
the issue, and second is the FDA approval. Where when we start talking about convincing the patient, when the patient asks you, I want a Lucentis and I don't want a biosimilar, then probably the way I explain is, you can have a shoes from a local market, you can have a shoes from a branded company as well. And that is the edge where you have. You can have the effect, the way it works, everything is well proven, well analyzed, and that is where probably Lucentis is much better than the other.
This is the biggest marketing point I think Ramesh has, that if you tell a patient this is a whatever branded or local or whatever, patient, in fact if I am the patient, we will go towards that unless there is a huge cost difference. And today, thanks to the innovator molecule, the cost difference is not much at all. Not much at all.
Exactly.
So I think Gagan also raised that point of chart.
I think because I personally feel that there is a different categories of patients. There is one category which wants the best, and they just want the best. So they're not bothered about what you're giving, but they want the best. Then there's a second category which which are going to just take what they're given. And then there is a third category who are always going behind this thing that, Doc Saab, which is the most safest, which is the most studied molecule? Aapne kitna sabse zyada diya? You know, those kind of questions come in. And that is where probably Lucentis still is probably the only drug which holds.
Yeah, Tinku,
True.
you want to add something?
Gagan, you showed cases where the patient himself chose to
Yeah.
get
Yeah.
Lucentis. So what are the indications in today's times that you would choose, you know,
Okay, so
eccentrics on your own rather than the
DME is something as a primary drug I would not choose, and I would choose Lucentis over any other molecule, probably to eccentrics, you know, in DME. AMD, frankly, probably not as a primary treatment if I was to choose that, and especially because I still go back to the gold standard ways of doing an FFA, ICG and OCTA today, and I don't think that I would use Lucentis, frankly, as the first line. But yeah, DME, I would not, you know, I would not mind using as the first line of Lucentis.
Anybody else,
today
any
as
point,
well.
please? Any from the audience? How do you choose innovator versus? Yeah, yeah. You can have a roving mic. Yeah. माइक दे दो
Mike, please.
माइक को ऑन ही रखो ना बार-बार ऑफ नहीं
I think that most of the patients don't understand what innovator molecule is. The age, I think, is the cost, number one, and number two, the difference between imported and Indian. That's all.
I agree because you see it's a marketing gimmick nowadays. You see, you tell any patient that ये imported है और ये local है, so immediately वहाँ जाता है. दूसरा cost issue आ जाता है. And third, very important thing which Ramesh told us is safety concern. Although everything is you know, safe with biosimilar also, but if you have an edge, because the key word what Gagan told, edge, their tilt towards innovative will definitely be there.
Sir,
Sir.
I am from Medical College Patiala,
Ji, sir.
where I deal with the not well-to-do people, poor family people. And I have never used the Lucentis. I am using Zydus company, and I am getting the excellent results.
Yeah, yeah. You see, there's,
I'm getting
I
excellent
agree.
results.
I agree. You see, the point of discussion was not that Avastin does not give or Zydus does not give results. Results are there in, you know, you are
I'm
using
giving
Zydus.
Ranibizumab.
Ranibizumab. That's what I was, you know, why I caught him was about the biosimilar. So many biosimilars are, and everybody is using. You see, if you see his patient sheet also, majority will be biosimilar.
Yeah.
There's no doubt about that. So, but these points are worth debating. I will point you directly. Suppose मेरी आँख में लगाना आपको तो आप लगाने वाली वो होनी चाहिए जैसे सर आप ये लगवा लो आप बात वो वाली बात आ जाती है because of the wealth of data, because of these 73 lakh patients have been given, and because of you know, so-called safety issue. Cost is not a consideration today because believe me, cost comes secondary. Cost becomes secondary. अगर मेरी आँख में फ़ायदा हो जाता है ना किसी वहाँ से तो I'll hook or back get that molecule. So safety is of prime concern. And costing of, thanks to you know, so many schemes floating by every company, cost is not much difference at all.
It is not a difference at all now.
So thanks Gagan for
Thank you.
exciting this useful debate about innovator versus biosimilar. And with the, I still believe your statement that old is still gold till the time platinum comes, sona to sona rahega. And because of the wealth of data, because of trust factor of safety and cost not being much of a consideration. So let's move on. Let's move on to Dr. Vikram, who will tell us about early intensive treatment in AMD. You see, both these words are very significant. I hope
Yes.
you know, Vikram will address why early and why intensive.
Yes, I'll do my best, sir. So, very good afternoon to everyone. So, as I said, thanks to AIOS, thanks to Novartis for holding this session. So, my topic is early intensive therapy in neovascular AMD. So, this is, of course, a Novartis-sponsored session. So, as sir was saying, why early and intensive? So, AMD is a progressive disease. We all know that. It is not only progressive, it is a very blinding disease. And it can cause blindness in a rapid amount of time. Let's say it can cause irreversible damage in a short period of span. So early therapy is very crucial. So a delay between the first reported symptom and anti-VEGF therapy has been shown to be a significant predictor for poor visual outcomes. A 2.6-fold increase in the risk of poor vision with a delay of more than 21 weeks when compared to when the treatment was started for 7 weeks. So also eyes in which the treatment interval was for more than 5 weeks initially, that is when they were not treated intensively, they ultimately required a longer time to achieve disease quiescence and required twice as many injections over time. So that is why for preserving the vision, early therapy is very crucial. And for sustaining and having lesser number of injection, increasing the durability of your treatment, giving intensive therapy early is very crucial. So rationale for early intensive, of course, we want a rapid VEGF suppression, which will reduce the retinal damage, improve visual outcomes, and will ultimately lower the treatment burden. So as we were also discussing what is the treatment landscape, we almost now 20 years of anti-VEGF era, and now from the first generation, we are moving towards the second generation, that is the brolucizumab and faricizumab, which prove to have longer durability than the previous class. Biomarkers of treatment response, we all know that we depend on clinical findings, imaging findings clinically. If there is any visible heme, PED, we want to do OCT, of course, is the standard of care of looking the disease activity, SRF, IRF, SHRM, FEPD, and other tools like OCTA, FFA, ICGA also help us in monitoring the disease activity. So treatment strategies, that was my talk also, okay, what were the treatment strategies? So we know that there are 3 treatment strategies widely popular. One is, of course, fixed dosing, where you give loading dose and then you continue monthly and bi-monthly injections. But this is, of course, not practical in real world. It can only be done in the studies. It's totally impractical. Next is what is most commonly followed in our country or in most of the world is is PRN. So here you give a loading dose and after that as and when needed. But the pitfall of this is that it's a reactive approach, and sometimes it causes almost 40% of the patient get vision threatening recurrences with this, and they can lose vision. So treat and extend is the best modality, which has incorporates both of them, that you give the loading dose till the disease is quiescent, and progressively, rather than giving fixed monthly, you progressively increase the treatment interval so that you reduce the number of injections and the disease remains in the maintenance dose. You are continuing the maintenance dose and the disease is quiescent. So this is, of course, this is known as a proactive approach, where you don't want the disease to be active again. So best strategy, of course, a number of trials have shown that treat and extend and monthly regimens are definitely superior to PRN dosing for the points that we discussed. Treat and extend significantly reduces treatment burden and is non-inferior to fixed dose regimen, so you don't need those many number of injections. And as I earlier also said, that 50 to 70% of patients with PRN regimen report recurrence and sudden hemorrhage causing sudden acute vision-threatening complications. Also with PRN dosing, you have greater fluctuations in CST. So a greater fluctuation in the retinal thickness is associated with poorer final visual outcome at the end of 4 years, 5 years. So this is a pooled post-hoc analysis of the CAT-E1 and Hawk and Harrier data, which showed that higher CST variability, wherever there was high variability in the central subfoveal thickness, the final visual outcome was poor. So treat and extend is considered best practical approach. But then is it the best practical approach? Because there are some pitfalls of treat and extend as well. So most of all, that although you need lesser number of injections than what you do for monthly or a fixed dose regimen, but you still will need a lot of injections. So this is almost a 3-year data of a European data from the FIGHT Retinal Blindness Registry of almost more than 10,000 patients who were followed up for 2 years. So they categorized these patients into 3 categories. One was high treatment burden, one was low treatment burden, and one was the tolerable and the best treatment burden. So in low treatment burden, this was at the end of 2 years, there was a particular segment of high treatment burden group which required injections every 6 weekly. Low treatment burden group required almost about, let's say, between 6 to 12 weeks, and few of them required more than 12 weeks. So total number of injections in 2 years in the high treatment burden group was 19. in 2 years, that is almost every month, 20, out of 24 months, 19 months. In low treatment burden group, it was 14, and for tolerable treatment it was 10 injections. So a number of patients achieving more than 3 months treatment interval where we can prolong the treatment was only 26%. Almost 75% of the people still needed monthly, 2 monthly, 3 monthly injections for, even after 2 years. Again, another point here, that approximately 50% of the patient, they did not even continue treatment after the first year. So those were also not included itself in the study. So most of the patient, they get fed up of the injections. They don't want to take any further injections. So because they have too many visits, poor response. So this is again a very unmet need, even with treat and extend. 40% of patients who completed the 2 years still had CNV active at the end of 2 years. So again, you need a more potent drug. You cannot have so many injections, almost 19 and 14 injections in 2 years, and still there will be active CNVM. So that is really an unmet need. So even the study said that you need more potent and longer acting therapeutics. That is why even the FDA has now shifted its, they're not like entertaining any new drug just for the sake of it. They want only durability now. So this is the data from Hawk and Harrier study, which showed that brolucizumab is both more potent and more durable. If you see the change in the central subfoveal thickness, the drug is more potent and you need lesser number of injections. And if you see the variability of the graph, if you see the upper one aflibercept graph, you have a zigzag appearance, whereas in the lower graph, the blue line, that is brolucizumab, you can have a maintenance dose. And if you see that you don't need a lot of fluctuations, you don't have many fluctuations, and this was achieved with lesser number of injections. So this is what a tailored treatment algorithm, which I normally follow. I try to follow wherever possible. So you cannot directly treat all AMD patients in the same way. So I have classified, because some patients are very demanding, some diseases are very demanding, some are, they do well. So a type 2 CNVM or a type 3 CNVM are known to respond to all anti-VEGFs almost. So of course, treat and extend regimen would be best, but PRN is sometimes practical in these patients at least, that you can go ahead with PRN. You can use any drug you want, because most of them will respond to the therapy. But again, even if you are doing a treat and extend or PRN, with brolucizumab, you will have least number of injection, and it is better for PRN dosing. So in our study, we did a retrospective analysis, and we found that over a period of 2 years, the number of injections required in first year with brolucizumab with PRN dosing was only 4. So then there comes another class that we all know, like they are very resistant. They want multiple injections. They are very aggressive. That is type 1 CNV, PCV, sometimes one-eyed patient, where you don't want to be leave it to a PRN. So fixed dosing is best, but of course it's not practical. If possible, it is the best. Treat and extend is the preferred. I would rather want you to avoid PRN if at all possible, but of course sometimes it is not in our hands. The patient has a lot of other problems that you may end up having a PRN, but treat and extend would be preferred for a PCV or a type 1 CNV. And here also I would prefer a stronger acting drug, a more potent drug, rather than choosing, let's say, a ranibizumab or any biosimilar. I would prefer brolucizumab, either brolucizumab second generation drugs, aflibercept, and then ranibizumab. So for brolucizumab, what I normally follow is I get two doses, 8 weeks apart, and after that I follow them 12 to 16 weekly. They need multiple injections, followed by 12 to 16 maintenance dose. So by this way, you can have about 5 to 6 injections in a year with brolucizumab. So I'm just going to highlight a few of my cases here, why early and intensive therapy AMD works. So it's a 47-year-old male, classic PCV with big PED. We can have, so we gave him 1 injection, aflibercept. We started with aflibercept here, first dose, second dose, third dose. So patient PED's height is getting better and better. We went for 4th dose as well, because you want disease to be quiescent. But even now, after 4th dose, his PED in fact has increased. So now we are in a spot, and now we decided to shift the drug, and we switched to brolucizumab. And with just 1 injection, you can see the effect that we've got a very wonderful flattening of the PED and absolute resolution of the SRF. also, then he again received another injection almost 12 months later. This was our earlier days with brolucizumab. And he has received just 2 injections post-switch. And also, I feel the early intensive therapy also played a role in this, that there was early, very intensive therapy given, which probably led to closure of the polyp. So this is the second case, again, where we went ahead and did early intensive therapy. We can see large PED, PCV patient. We gave him first aflibercept, second aflibercept, third aflibercept. These are monthly injections which are continuing. Then 4th injection, then 5th injection. So after 5 injections, in about 6 months later, we started in December 23, and this is May, last scan is May 24. Now we have the disease quiescence, and at this point of time, we extended the interval. But now we are again back to square one. And this time, again, we shifted the drug and we changed the molecule. We shifted to brolucizumab after discussion with the patient. And with just after 1 dose, we have achieved this wow effect. So if we this is just 8 weeks post brolucizumab. And if we see the journey of the patient, it took 5 ILIAs in 6 months to achieve from here to here, which was almost similar OCT. In fact, the OCT PED height is bigger in the recurrent scan. And we can see we achieved almost similar result with just 1 injection. So definitely, it's a very potent drug. And we are maintaining, this was in 24, we started this treatment. I just saw her 2 days back, and we advised her now again an injection, and she's receiving now 3 monthly injections. Almost 3 monthly she needs injections. So this is a PCV patient, and you can maintain them at 3 monthly intervals. So that is 4 injections in a year, which is acceptable. Of course, we will want no injections, but it's still acceptable. So what happens when you give in treatment naive cases? So this is again a PCV patient. As I said, we prefer brolucizumab in PCV now. And just 1 month post-injection, you see beautiful flattening and resolution of SRF. But then again, patient gets another injection after 2 months, 8 weeks apart. And after the second injection is doing very well. And we could extend the treatment interval to up to almost 4 months now. He received the 3rd injection in, after 4 months gap, 16 weeks interval. And post that, I again gave 1 more injection at 16 weeks. Now we can see, because the PED height was again increasing in size, although there was no SRF and IRF, but because of the height of the PED, and we knew the disease is going to recur, it's PCV, so we again injected. And so we gave an intensive therapy again here. We did not wait for SRF or IRF to develop. PED height and sub-PED fluid was sufficient enough biomarker for the disease activity. And we gave the injection, and patient has not received any further injections till now. So he just received 4 injections in almost 18 months. So now, of course, the emerging concepts which are coming is port delivery, that the Susvimo has got an FDA approval now. Gene therapy is in the pipeline for both ranibizumab and aflibercept. AI, a lot of deep learning modules are going on for assessing the fluid OCT parameters and counting the fluid in microliters, which will help us in further continuing our therapies. So to summarize, my key takeaways would be that early and intensive anti-VEGF therapy provides best visual acuity preservation. And with AMD, we have to know that we have to explain to the patient that treatment will continue for years. Tailored treat and extend regimen, which I would like to follow, should depend on, we should have certain characteristics like CNV type, which drug we are using, and the patient profile, whether he can afford, and that should be the criteria for having tailored treat and extend regimen. Brolucizumab has a strong drying effect, low durability, and allows flexible dosing, and is more suitable for real world. Thank you.
Mike, thank you, Vikram. One of the nicest talks, practical talks I've heard in recent times is this. So a lot of questions, I think I'll love House also to participate. 1 or 2 questions is, you said Q8,
Yes.
2 injections, then
Yes.
Q12.
Yes.
You follow this regimen irrespective?
Most of the time now, yes. With the experience now, yes. In PCV, not in type 2 or type 3, but in PCV, type 1 CNV, I do this now. With the experience that I have gained for 5 years experience, what I have gained with brolucizumab, Now I do that.
I slightly do it slightly. I say Q6 for 3 and then shift to Q12 or this thing.
Okay.
So that may be slight variation. And second point is about, you see, like you said PRN, I think in AMD, PRN has to be discouraged. Always, always.
True.
This is what I tell. DME is okay, you know, you can play with it.
Yeah.
But in ARMD, you...
No, sir, I said,
I-
in
you-
type 2, type 3, you can still, I still feel type 2, type 3 because they respond very well.
yeah,
So
yeah.
Of course, you should
But
not.
but still,
yes, you should not.
Still, yeah, I agree. The second, that graph which you showed was very, very, worth emulating. In fact, where you showed type 2, I don't care. Type 2, you can start with any drug,
Yes.
any biosimilar you start.
Yes.
And if it is not, switch after 2 injections. I will switch after 2 injections. I will not wait for 2-3 injections. And in type 1 PCV, in fact, I have been barking for, till the time brolucizumab had come. So right after experience of 13 eyes, we had said that it is very good for IPCV and PCV eyes.
Yes.
And that I think still holds true. And at that time, we had presented 13 patients on experience of brolucizumab. And I am happy that you are having a similar kind of experience. But question to you is that you said brolucizumab / faricimab / aflibercept / ranibizumab.
That
Is
the
this the order
sequence
which you go?
order.
So that
I would
means
prefer
people who
preference.
are not responding to brolucizumab can respond to faricimab?
Not that way, sir. In the sense ki if patient is not willing for brolucizumab, then you go for faricimab. If he cannot afford faricimab, you try Eylea. If he cannot even afford Eylea, then you go to ranibizumab. Go with treat and extend with ranibizumab.
देखो patient की बात अलग है यार.
Yes.
Patient will go by whatever
Then
Vikram
I
says.
have
I'm
never
telling you,
seen
patient will not go
brolucizumab
by.
not responding.
I do not give a chance
I
to
think-
patient. Patient को chance तो देने का point नहीं है.
True.
Patient will ask you. Patient in this country, believe me, is dependent on doctor क्या बताता है मुझे.
Yes, yes.
If I am telling you, I am a sufferer myself of some disease, so whatever doctor
Doctor
guides
is
me in the best interest, we follow that.
Yes.
Rather than giving a chance, आप बताओ जी आप ये लोगे, ये
True,
लोगे, ये लोगे या biosimilar लोगे, that is not the best way of treating human eye.
Yes.
So like Dr. Vikram said, I think there would be a very few subset of patients who will not respond to
Yes.
brolucizumab,
Yes.
like you were saying.
Yeah.
I think out of all the molecules, this is the one which has that, wow effect, like the pictures you showed, the PED coming down, the fluid vanishing.
Yes.
So you get, and very quick results. So quick that sometimes I think in those large PEDs, you sometimes have to be careful. You may get a rip because it works so fast.
So the
and so quick.
buzzword in anti-VEGF era today is durability.
Yes.
Everybody is talking of durability. You see, first generation is 4 to 6 weeks. Once we're talking second generation, we are expecting at least Q12 or Q16 sometimes, or maybe more. So the question a lot of people ask me, Dr. Sahab, ये treatment khatam kab hoga? So what do you tell these patients? ARMD, it will be till death or till?
So at present, I give them a 5-year timeline. I don't want to discourage them also. I give a 5-year timeline. That first year, depending on the drug that is
Gagan,
being used.
Ramesh, or anybody else would like to? Prashant is here, chairman here. You see, what we are discussing is in an AMD patient, a lot of people ask, Dr. Sahab, injection, कभी 6 हफ्ते, कभी 10 हफ्ते, 12 हफ्ते, ये खत्म कभी होगा? How do you, this is a very frequent question, everybody must be facing this.
Yeah, everyone does face this truth and this question. We need to answer not exactly, we cannot be evasive about it just for that the patient continues with us.
Yeah, what do you
We
tell
have
your
to be
patient?
truthful.
What do you
For
tell?
me, I tell them कि yeah, you have a disease, probably regular treatment से आपको आगे चल के frequency कम हो सकती है, पर जब तक आप हो लगने की पूरी संभावना है, but 70-80% में you might have a
Only
drug
thing is
free
you can
interval.
reduce the number of injections,
Yes,
not.
exactly.
So
So
you
what
have to
I-
give them
yeah.
some optimism,
Yeah,
I
so
believe.
what I typically say, sir, 5 to 6 injection first year, 3 to 4 second year, 2 to 3 third year, again maybe 2 fourth year, 5th year, like that you will need for 5 years, at least.
We give them some random statistics by saying almost
Yeah.
30-40% may you can be disease free for a good period of time. So that gives
So
them
I
a ray
will,
of
I will
hope.
reiterate one thing, that we should discourage PRN in all patients of NAMD, even type 2 also, because AMD is not a forgiving disease, especially especially PCV.
Yes.
Anytime you can have a hemorrhage,
Hemorrhage.
and you regret. In fact, recently I had one doctor doing very well, 6/6 vision, and for some reason, I was not there, and he came after 2 years with a massive bleed again. So it's
So
not
that reason
possible
also
to.
we are also quite puzzling. Sometimes we keep doing ICGA also 3 monthly, 4 monthly, but still you cannot predict who is going to
So only thing what I have done in my practical real world is that if patient has 3 consecutive, 6 weekly or 8 weekly visits, similar OCT, similar this thing, you can have a drug holiday. You cannot say we अब इलाज नहीं चाहिए, वो तो बहुत मुश्किल है कहना. Other thing is that anti-VEGF load is not same in everybody. Anti-VEGF load in my eye,
Yes.
your eye may be different. So you follow one size fits all treatment, or this regimen is for everybody, जो भी PCV का patient है, or type 1 CNV.
Ideal तो situation हो नहीं पाता है कभी, because of course lot of variability is there. But if I want to do it for my eye, maybe probably I'll do that. But of course there is a lot of variabilities, lot of factors, logistic issues. But if you ask like that, for PCV I would like to follow this, because we have had instances where certain hemorrhages occurred and then the vision is lost.
What about PAEHCA, peripheral exudative, variant of PCV which is in the
So we
periphery?
try to do laser and not just one anti-VEGF laser, not much.
Sometimes.
Yeah. So do you
Sometimes they do
Self
need
resolve.
more injection, PHCR,
Yeah. PHCR is often an undiagnosed or underdiagnosed entity.
underdiagnosed.
You see, other last question for everybody is, you see, you show 2 examples of switch,
Yes.
1 patient of naive.
Yes.
So, and all of us believe, Tinku just said that, it's a very potent drug, durable also. Why most of us, most of ophthalmic fraternity, most of retina, VRSA members also, they will switch, okay, but they will, treatment naive, they will always have fear. Why so?
I think that
Because everybody says it's very potent.
Yes.
Everybody, is there that fear of IUI
no,
or
earlier,
vascular?
of course, sir, that is the biggest fear that everybody has. But fear is, of course, but we have, touchwood, never had such phenomenon. And in Indian eyes, we did a study also that there are very few, only 0.9%, and out of those 0.9, also 0.7 were mild only reactions. We have had mild reactions, but we've never had any occlusive. What everyone is afraid of is occlusive vasculitis, that we have had reports of European countries and American, and that there was complete occlusive vasculitis which has resulted in loss of vision, which of course everybody is afraid. I believe sometimes even Novartis also has little apprehension about it. So that does play a role in that.
So I'll ask this question to all 5 of us, Gagan, Tinku, Prashant, and
I think that is the only rate limiting about
You
it.
see, people are so confident that they'll switch after 2 injections, that there is a reason, na, bhai respond nahi kiya to you
Yes.
switch.
Yes.
So then that fear also may be slightly subdued, but Dr. Saab ne mujhe samjha diya tha, वही इसलिए कर रहे हैं. But treatment naive, when ophthalmic friend comes to you, what do you?
Sir, to be precise, I have changed my protocol. Somehow I have gained a lot of confidence with this molecule. We started using early, we were amongst the early users. And I think we are having a lot of skepticism because of the fear of IOI, which is, I think, overhyped, I believe.
Yes.
In my experience, probably where we use about, I should say about 300 injections per year. And in last 4-5 years, I might have completed about 1200, 1500. Touch wood, I didn't have any occlusive vasculitis. 1 or 2 cases, we had mild inflammation, which happens with any of the anti-VEGF. So we don't need to worry about. And regarding your first question, whether do you use in a naive cases? Yes, of course. We are using at our center in naive cases also. We give them a choice of a bouquet of choice of various anti-VEGF molecules. We tell them very precisely, see, any ranibizumab or anything, you will be using this molecule at 4 weekly intervals. So in a year, you might end up in the first year needing 8 to 10 injections. While with this molecule, you might end up needing 3 to 4 molecules or injections only in a year. And many of the patients are ready to pick up this particular theory of it. And this is important basically because the context in which we are placed in Indian countries, where we are placed in economically backward zones of our country. Money is the most important factor in deciding the molecule besides the whatever we as a surgeons propose. So I think it is ill-profounded, unnecessary fear that we are not using in naive cases. I do use it.
So you think that, you see, everybody wants the most potent and most durable.
Correct.
Nobody wants the least potent and
Very true.
less durable.
Very true.
So should we throw away all other anti-VEGFs?
I would not say that. See.
No, reason I'm asking is, dekho, it's a practical world.
Yeah.
Patient wants the best, patient wants the most durable also. And if you today say that this is your choice in treatment naive also, then where are we?
Exactly. See, sir, we need to understand we cannot treat the patient in separation. We need to understand his socio-economic as well as his financial status while making a
The
decision
reason
for the
I'm asking
molecule.
is that, Professor, he uses Zydus ranibizumab.
Okay.
The reason I'm asking, suppose, it's a theoretical, suppose this was a very low price drug. Instead of giving it at whatever price they sell it, I don't know. But suppose it was a low price, say 10,000 rupees, or will it become number one?
I think so. I think
It
so.
will
For
definitely,
majority of the
Definitely it
indications,
will.
of course.
Ramesh?
Of course.
It will.
Yeah.
Because I have a very different mindset in this, that you want to treat with the best drug so that it has got the
Best
best.
is relative. What is
No, no,
best?
best is something which will retain his vision it will help in
So
reducing
what is the best according to you?
in AMD management.
Yes.
In AMD management, if you ask me, it has to be brolucizumab because of the wow effect which it initially produces. See, a patient is very upset that
Not faricimab.
not faricimab.
Why?
Okay. Faricimab efficacy wise, it's yes, but durability wise, because when the drug was marketed to us for faricimab, it was marketed on the durability and the extended durability of 16 to 20 weeks.
Yeah.
Understood? And that has failed. To be very frank, that has failed in the real world situation where it is not able to reach 16, 12 to
Efficacy
20.
wise, it's equivalent.
Efficacy wise, yes, it is quite comparable. But even in terms of PD resolution, brolucizumab is the best drug,
Far, far better.
far
Far
superior
better.
than
Yes.
faricimab.
Totally agree.
Tinku, your take?
So again, like I said, it is one of the most potent drugs, and in my experience also, I've not had any serious IOIs. I think we need to be vigilant. Why patient selection is very important. Like patients with a history of uveitis, we should not take them up. Also, a close follow-up of patients. Like I would call these patients the next day. In the beginning, when I started using this, I would call them the next day and be in touch with them over the phone. But over the years now that experience is built in, I'm more relaxed. So I think it's a wonderful molecule. Gives us the best results. Gives us durability. And safety, of course, there are a lot of studies now in Indian eyes, and our experience also has borne that it is a safe drug. So
Yes, Gagan.
it is
So I just
my
wanted
drug
to
of choice.
ask,
Ramesh,
I
you
mean,
can- Ramesh, you can
there is no
really-
doubt that brolucizumab works very well and it's extremely potent. But as Vikram also showed these cases, so do you have any difference in your first line of management when you have a very high PED with the risk of RIP?
And
Would
that
you
is-
go in for a smaller, a less
No,
slowly?
my drug of choice in symptomatic PEDs required treatment is brolucizumab. And, there's no ambiguity about this. And it really works in flattening much more than, as Prashant was saying, much better than any of the other drugs.
No, but what about risk of
In
RIP?
fact, we never had, sir.
Never had.
We've never had. So I've tried to make a hypothesis around that also. Maybe it is such strong acting that PD is getting flattened, it's not getting ripped, and rather than the tractional forces of that is the more responsible for PD. So a slow thing is, we never know what is causing, but we tried to analyze how many rips did we get. We never had a rip.
You see, RIP can happen after treatment, RIP can happen spontaneously also, RIP can after PDT also, RIPs can happen. So to blame a molecule for RIP may not be.
No, that's perception that a high PD will rip.
This was there
I-
when
it's
the
not
drug
there.
came in.
Just
I
make
think
a
a lot
small
of us were skeptical that it would cause a rip since it was
If
so
I could just make
potent.
a small comment
But
in
I
Vikram's
think
case, with
I
the
haven't
large
seen that
PED which
happening.
flattened, I think there was a rip which has
So
actually
I also,
flattened.
because the ultra that
Because
IR
you
image
had
shows
overlying
that,
strem over it.
the IR image shows,
So that
suggests
said that it
I
is not
went
a
back and
flattening of
saw
the
it
PD,
again.
it's a rip which has caused the flattening.
So I've again went back and seen it's not that. There's no rip in that.
Okay, next, let's hear now Dr. Ramesh Venkatesh, very, very lucid speaker I have, encountered, is efficacy versus safety. Because to my thinking, safety is of first importance. Then comes the efficacy, then comes the cost in that sequence. Because you see Hippocrates oath or whatever you talk, do no harm is the first mantra in medicine. So efficacy, safety, we'll hear Ramesh what has he here to say.
Thank you, Lalit sir. So this is a very interesting talk. The topic itself is very interesting. It's going to be balancing efficacy and safety with anti-VEGF therapy. And when we talk about anti-VEGF therapy, I'm going to limit myself basically to brolucizumab. So this is the disclaimer slide provided to me by Novartis, and we know that most of the treatments for most of the retinal and choroidal vascular diseases are anti-VEGF in today's day and age, whether it's neovascular AMD, CNVM to any other cause, diabetic macular edema, or even venous occlusions. And anti-VEGF has always been the mainstay in the treatment. And within the last 30 minutes, we have already spoken about multiple anti-VEGF drugs. We've spoken about Avastin, ranibizumab, both the innovator and the biosimilar molecules, aflibercept, brolucizumab, and even the latest faricimab. But let's talk about what do we look at in the properties of any anti-VEGF molecule. So according to Dr. Lalit, he said safety goes higher up. For me, it is the efficacy which goes higher up, in the sense that if a drug is not working at all, then there's no point talking about safety. Okay.
No, the reason I said, the reason I agree, efficacy I agree. The reason I said, because efficacy-wise, most of them, if not in all patients, will show reasonably, efficacy.
Okay. So, but efficacy is very important.
But if my first patient develops some side effects, he is not going to come back.
Okay. Then I look at the safety. Then once the efficacy is proven, in the sense when I'm talking about trials and data and everything, for me the drug has to be equally efficacious or superior to the gold standard molecule. And then comes the safety of the drug, then comes the durability, and last and finally is the affordability. And we have been talking about affordability all this while in the last 30 minutes. Let's talk about brolucizumab. Brolucizumab is, you know that it's the smallest anti-VEGF molecule with a molecular weight of around 26 kilodaltons. It has got high molar dosing and high drug concentration, and therefore it's given in a dose of around 6 milligram in 0.05 ml, achieving concentrations almost 11 times of 2 milligram of aflibercept and 22 times of 0.5 milligram of ranibizumab. But let's understand brolucizumab. In 2019, it was approved for neovascular AMD. And it was designed for better drying effect and durability. And the reason why it was designed for better drying effect and durability was because of its small molecular weight, high molar concentration, and therefore deeper penetration into the retina and the choroidal layers. And the entire goal or objective of giving a patient treating them with brolucizumab was to extend the dosing intervals and achieving comparable or even better efficacy. So we had two landmark trials, one for neovascular AMD, which was the Hawk and the Harrier trial, and the diabetic macular edema, which is the Kite and the Crystal study. Now, when you look at you look at the outcomes of these trials, you would realize that in terms of visual acuity, brolucizumab is non-inferior to aflibercept. That is the first important take-home point, that it is non-inferior. Second, it has got a greater CSFT reduction. That means it's in terms of macular thickness reduction, it is better. The percentage of eyes achieving normal central macular thickness is very high compared to aflibercept. And more number of eyes were able to achieve a Q12 dosing. These were the 4 important outcomes which you had from the 2 important clinical trials for neovascular AMD and diabetic macular edema. Now let us see what happens in real world cases. So this is a 70-year-old female complaining of blurring of vision in the right eye since 2 months, no systemic illness, and previously already treated with 6 Avastin injections for the right eye with CNBM, and the last injection was almost taken 2 years back. Now this was a period where there was COVID in 2020, and this is the single-eyed patient. So she has vision of 648 in the right eye, finger counting 1 meter in the left eye, and look at the clinical photographs. What you can see in the left eye is an entirely scarred membrane with very poor visual prognosis. Now the left image on the top left is the image when we left the case in December 2019, where you had the CNVM almost flattening out, no fluid. And this is the time when the patient comes to us a year later and comes to us with subretinal fluid. And you can see the typical bridge arch shaped fluid which you can see in a chronic fibrotic CNVM. Now most of us would have actually said that, oh, it's a very poor visual prognosis and we will not be treating this case. But we decided that we'll give this patient 1 injection of brolucizumab because we wanted a longer interval and longer durability as well. And we call this patient at 1 week post-injection because this is a time where we were talking about intraocular inflammations and retinal vasculitis and vascular occlusions. And in 1 week, you can see that this OCT is totally flat. The fluid has totally resolved. And this effect is maintained even at 4 weeks with the visual acuity of around 6 by 60.
This is the brilliance, I'm telling you. This never happens with anybody. With first week, show the previous slide. That's 1 week after injection, you see there is anatomical as well as some functional response.
And this effect is maintained even at 3 months post-injection. So this was the first case, to be very frank, I treated with brolucizumab, and this is the effect which I got at the end of 3 months, and that was sustained and maintained as well. Now let's look at case number 2. It's a case of peripapillary PCV. A 72-year-old female, diabetic and hypertensive with a visual acuity of 6/9 and 6/8 in right eye and left eye respectively, pseudophakic in both the eyes. And look out how the presentation comes to us. Tall PEDs in the superior aspect with extensive exudation. And when you look at the ICG of this patient, you can see that there are multiple bunches of polyps which are present on the superior aspect of the disc and also on the temporal aspect of the disc. Now this patient took loading dose injections at monthly intervals with brolucizumab, 3 monthly loading dose injections, and what you could see at the end of 3 months is that the PED has flattened out and the exudation has totally vanished away. Now we did a repeat ICG in this patient at the end of 3 months after the 3 injections, and we wanted to see whether the polyps have regressed or not, because in PCV, our ultimate objective is not achieve only the drying of the fluid or the drying of the PED or the reduction in the hemorrhage. We eventually want the complete regression of the polyps. And this is what you can see at the end of, 3 months post-injection, where you can see the repeat ICGs clearly telling you that the polyps have significantly reduced or regressed, and there is just staining of those polyp features which you are seeing. So this is the pre-treatment FFA ICG, and this is the post-treatment FFA ICG, and you can see the significant difference which you can see in the regression of the polyps as well with loading dose injections of brolucizumab. Now let me show the case number 3. This is a case which is almost similar to what Vikram presented. A 65-year-old male with a visual acuity of 6/12, phakic, diabetic as well, and complaining of blurring of vision since 15 days. And what you could see is a few exudates, STREM, and also a large PED which is present as well. Now this is 4 weeks after the first injection of brolucizumab. The exudation reduced, the STREM reduced, but the PED did not flatten at all. And this is where we were a bit upset. So we decided, chalo, let's give the second injection of brolucizumab. And again, the PED did not flatten. So we were very, very upset what happened. Oh, the PEDs were supposed to improve with brolucizumab and it did not improve. But we decided, let's follow the Hawk and Harrier trial and give the third injection of brolucizumab as per the trial protocol and see what happened here. The PED totally gone away, and this is not a rip. Okay, this is not a rip. This is just regression of the PED which we achieved. So these 3 cases which we spoke about is basically cases of chronic CNVM, which are, one was a treatment switch case, a case of PCV in a treatment naive patient, and third was a case of treatment naive CNVM or a type 1 CNVM as well. And what you would realize that in terms of efficacy, brolucizumab definitely is testing positive in terms of achieving a very good efficacy. Now let's go to the safety aspect of the drug. And I'll start the safety aspect of the drug with the real world evidence which we have already published in IGO in June 2025. So this study basically talks about the brolucizumab results and adverse visual outcomes, and it's a single center real world experience which we published recently in June 2025. So this experience, these numbers are much more than what we have published in literature. This paper basically spoke about 926 injections of brolucizumab in 450 eyes of 390 patients. CNVM was the most, or AMD was the most common cause for the indication for the treatment, followed by diabetic macular edema, and 30% of our cases were treatment naive. This is a very important point which I want to tell, is that we don't fear anymore of giving brolucizumab in treatment naive cases. We want the best drug to be given at the best stage at which the outcome can be achieved. Post-treatment visual acuity definitely improved, but more importantly than the visual acuity, you are more concerned with the macular thickness reduction, and that was significant as well. Now let's talk about the fluid resolution. And you would see that the fluid resolution was significant in terms of the sub-RP fluid, the subretinal fluid, and the intraretinal fluid. And only 3 eyes, they developed intraocular inflammation, which was only 0.37% per eye and 0.74% per injection. That is less than whatever has been reported in international literature. Now let's talk about those 3 eyes which develop the intraocular inflammation, and it's important to know that the common diagnosis in all these 3 patients was neovascular AMD and PCV. None of these patients were diabetic macular edema cases. That's the first point. And when you look at the final outcome of all these 3 cases, all these patients, they regained their visual acuity almost to what we really wanted to achieve. That is almost from 6.6 to 6/30. So let's talk about the safety concerns, and the most important safety concerns from the global perspective is intraocular inflammation, retinal vasculitis, vascular occlusions, hemorrhagic retinal vasculitis, and this has been what is majorly concerning for us. Now, if you look at the IRIS registry and the ASRS, American Society of Retina Specialists alerts, we have spoken about intraocular inflammation rates of around 4.6% with visual loss in a significant number of patients. And the mechanism which has been postulated is that it's basically a type 3 hypersensitivity reaction. And what the people say that the minute you have an intraocular inflammation, stop the drug, regimen changes, you follow the emergency guidelines, and then only the patient can do well. But let's look at what the contrast is in India. The real world safety guidelines which we have published through the VRSI thing is a totally different scenario what we are actually seeing in the global world. We have very low incidences of intraocular inflammation, which is 0.1 to 0.3% in the Indian cohorts. And this is basically coming from the VRSI study, which says that it's only 0.79% inflammation rate. And there are no significant cases of retinal vasculitis or vascular occlusions being reported. Now, let's understand why there is this geographic diversity in the sense or disparity which is there. And there are multiple hypotheses which you can think about. The genetic and the immunogenetic differences between the two subsets of patients. The prior exposure to biologics, that means we are already using these patients, these cases who have already been treated with different anti-VEGF agents, and therefore your auto anti-VEGF or antibody levels are already very high in these cases. The injection techniques, think about starting these patients on pre and post-injection steroids, sepsis protocol, the storage and the handling factors, and more importantly, one would also say that we are underreporting these cases in the real world situation. But the question is, do all anti-VEGFs cause intraocular inflammation? And the answer is yes. Every anti-VEGF molecule has the ability to cause intraocular inflammation, whether it's aflibercept and whether it's the latest drug, which is faricimab, or even the biosimilar molecules like ranibizumab has been reported to cause intraocular inflammation. And when we talk about intraocular inflammation, we want them to be segregated into the anterior segment and posterior segment. We'll talk only about the posterior segment, where we are worried about three main complications. That is the vitritis, that is the non-infectious endophthalmitis, vascular occlusions, vasculitis, and cystoid macular edema. Now, how do we manage this intraocular inflammation? And there is a very good paper which has been published in Retina Journal 2022, which talks about the risk mitigation with brolucizumab-related IOIs. And what it clearly says that if you have anterior uveitis, the treatment is only with topical steroids or periocular steroids. But the minute you have intermediate uveitis, posterior uveitis, and retinal vasculitis, the treatment has to switch to more systemic steroids. So vitrectomy is reserved only for persistent cases or where there is severe vitreous inflammation. Otherwise, most of these cases, they are treated very well with topical and systemic steroids. And if you look at the visual outcomes of these cases, the 82% and more of these patients, they regain all the visual acuity back. So this is a very important point. And this review article, which has been published in APJO 2023, clearly tells that the risk of the intraocular inflammation with brolucizumab is acceptable and manageable. But what you need to understand is you need to do a good pre-injection screening for your patients. So let us look at this last slide, and it will tell us that when to choose brolucizumab. So most of us in real world choose brolucizumab when a patient is not responding to aflibercept. Second, we choose it in high treatment burden patients where you want longer durability. We prefer not to use it in uveitis or monocular patients. That is the real world situation. And we want to use it as a first-line therapy for neovascular AMD and PCV cases. But what's more important is the baseline screening, counsel your patients for intraocular inflammations, and have a close follow-up after the injection number 1 and injection number 2. And just want to end up with this concluding slide with cautious optimism, appropriate case selection, close monitoring. Brolucizumab can make a meaningful balance between efficacy and safety. Thank you very much.
It's very, very nice. The claps say it all. That excellent conclusion. And we'll just conclude this session because other people are calling. But with the statement that no fear, use the best drug, which I was saying in the beginning also, and obviously avoid in patients who have uveitis or one-eyed patients. But as the confidence increases, the more treatments you give. As the numbers increase, suppose I also had first patient who had scar and had some fluid. So that lady improved and virtually begged, Dr. Sahab, ye injection dobara laga do." There's no doubt about, so we'll request Novartis to reduce the cost so that it becomes number one.
I
So
think more
with
than the
that-
cost, you have to have patient support programs because everything in
That's
India goes
similar,
on free.
that-
Free. जो free मिलता है वो ले लेंगे.
So thanks again to the audience and thanks to Tinku and all the.
Thank you,
university.
sir.
Yes,
Thank
sir,
you,
yes, sir,
everyone.
please, please.
Excellent
There
talks.
is one important question for
Yes,
you,
sir, please.
Sir, can we give the anti-VEGFs in the patients with ruminant PEDs?
With?
Can we give the anti-VEGFs
In?
in a patient with the druidinate PEDs without fluid, with the visual acuity
I don't think so. You see, isolated PEDs we don't treat. It has to have fluid or metamorphopsia. Something should be there. It has to be a symptomatic PED.
Okay. No, we can't give it as a
Should not.
preventive measure.
No, no.
Right.
So thanks at all. Thanks everybody, and we'll just conclude because there is a pressure of going to the other session. Thanks Vikram and thanks Ramesh for excellent slides you have shown.
Thank you. Great cases. Everyone had wonderful cases. Thank you so much.
So we'll have a quick, Ramesh, quick group photograph.